Neither the El Paso County Medical Society, its members, nor KCUS TV shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Orthopedics. It's the study of skeleton and associated structures. Sure, it's tendons and it's ligaments, but we talk a lot about the general wear and tear of us getting older and sports injuries. But tonight, we're going to talk specifically about injuries that are traumatic to the system. So these are car crashes, these are very serious sports injuries, something that we don't talk very often about. And we've got 3 doctors here this evening that know all about it. In fact, we've got 2 of them in scrubs. Were you guys doing surgery today? Yes, look at that. So this is a live program. Call with some questions, 881-0013. This evening's program is underwritten by the University Medical Center. And we want to say a nice special thank you to the Paul L. Foster School of Medicine students for manning our phones this evening. They're live questions again, so they're the ones that you're going to be talking to. We also want to thank the El Paso County Medical Society for bringing the show to you each and every month. I'm Catherine Berg, and you're watching the El Paso Physician. Thanks again for joining us. I want to give a huge applause to everyone in the studio. If you are a watcher of the show, you'll notice that things look a little bit different this evening. We have this great panel of wood behind us, and KCOS is a public television station, always begging for money. You know how that goes. So literally, they picked up these pieces of wood from scrap and stained them, put them together, and it looks ridiculously cool. So really, guys, great job to everyone in the studio and everybody in the back. Fantastic. The lighting's a little bit different, furniture's different, so this is going to be a great show. Aside from the medical content, it's just kind of neat to have something new. But we have with us today Dr. Alan Tyrock, and you're like the trauma guy, and I mean that in the most beautiful and complimentary way. But Dr. Tyrock is the professor and founding chair of surgery at the Paul L. Foster School of Medicine. He's also the chief of surgery and trauma medical director at the University Medical Center. And then we have next to him Adam Adler, and Adam's not going to mess up. Adler's like, what do I do if I mess up? Because this is a live show, and it's like, we roll with it. It's kind of fun this way. Dr. Adler is an assistant professor at the Paul L. Foster School of Medicine, and he specializes in orthopedic surgery and rehabilitation. And then we have Gilbert Gonzalez, who apparently owns a lot of really cool-looking suits. But Dr. Adler said, please don't wear a suit, because I'm going to wear my scrubs. I didn't have time to go home, so you are a true friend. I like that. So Dr. Gonzalez is assistant professor at Paul L. Foster School of Medicine and also specializing in orthopedic surgery and rehabilitation. So you guys are obviously friends, and it's kind of nice to sit and listen to you guys chuckle and go back and forth. But I've given everybody your titles. What does that mean, though? We're talking, a lot of the questions are going to be separating trauma, orthopedic surgeries versus just, hey, I'm going to replace a hip because I'm 80 and it's just time. So Dr. Tyrock, if you can explain with your title, what does that really mean? What do you do all day, every day?
I pretty much just yell at these 2 guys.
There you go.
That's why they're in scrubs and not. And they didn't tell me they're not going to wear suits today. Actually, I think it was due to the traffic on West El Paso. Right. So what do I do all day? Well, I'm the chair of surgery at Texas Tech, so I do some education with the medical students and the residents. I'm the chair or chief of surgery at UMC, so I run the surgery program there with the other faculty and private surgeons. And I'm the trauma medical director. I've been the trauma director since 1997 or so. So we're the level 1 trauma center for the region. So I help with these gentlemen and a lot of other surgeons and physicians and other healthcare personnel at the county hospital take care of the trauma population in the region.
And we've known each other. You said 1997. We have done shows together since the very beginning, and this show is going on 21 years. And the reason I know that, my daughter was just born. She's 21. And we had her on the show, and we were going through car seats and how really bad things can happen to kids who aren't buckled in right. And I'm thinking, we've been doing this a long time. So welcome back to the show. It's really nice to see you.
Thank you. We're getting old, I guess.
I know. It's okay. You know what? We're alive and healthy.
I am. You're not.
There you go. I like that. I'm not getting old. Dr. Adler, you're nice and young. So, on that note, you haven't been doing this as long as Dr. Tyrock.
I have not.
But what do you do all day, every day?
When the patients come in as a trauma patient and Dr. Tyrock comes yelling and texting and telling us to take care of the patients, Dr. Gonzalez and I come running and take care of their bony injuries and their extremity injuries and try to put Humpty Dumpty back together.
Nicely said. And on that note, Dr. Gonzalez, I know you guys kind of do the same thing, but is it different a little bit? Do you guys have different roles, or is it kind of, I guess, just depending on what's happening that day?
Yeah, for the most part, Dr. Adler takes care of the long bones, and I'm the hand surgeon at UMC.
The hand surgeon?
Yes.
Okay. And there are a lot of injuries with hands because we do everything with the hands, so we'll go into that a little bit this evening as well.
Yeah, so definitely a lot of injuries here in El Paso and the area of influence that we have here. So all the accidents that happen around our town, they come here.
Okay. That's exactly right, and we are in a region. I wanted to say, again, if you want to have some questions to call in with, I wanted to introduce to you the people who are answering the phones. We have Karen Voss with us this evening, and then we also have Jeffrey Allison, and they've actually been giving, hi, perfect waves. I kind of like, Karen, I need you to sit on a phone book or two next time you come. Okay, there you go, I like it. But these lovely students, they're medical students. There's one a first year. Jeffrey, you're a first year, is that right? And then Karen, you're like the old lady. You're a second year. But these are the lovely people who are going to be answering the phones again, 881-0013. I'd like to start off, if we could, Dr. Tyrock, there's orthopedics, and we hear about orthopedics all the time. We do lots of shows on orthopedics, but it's usually hip replacement, knee replacement, sports injuries. What you do is different. It's the same, but it's trauma. And I'd like for you to explain what the difference is in your practice of wear and tear and true trauma in orthopedics.
So obviously they're the orthopedic surgeons, so I work with these guys closely as well as the other specialists. There's, I think, 8 orthopedic surgeons in your group, and 4 of them have they all have additional fellowship training of various types, but 4 of them are orthopedic traumatologists or trauma surgeons. Dr. Gonzalez is being nice, but he actually is a replant surgeon. If a finger gets cut off, a limb gets cut off, he replants it, so replantation. And his expertise is working on the pelvis and other orthopedic, very complex injuries. Not somebody, which is important. Somebody's playing football and they blow out their ACL. There's a lot of good sports orthopedic surgeons, which they actually have one in the department also. But these gentlemen, and there's 2 ladies in the department in orthopedics that take care of patients that have severe injuries. Without giving too many details, just this week we had a patient that was sustained multi-system injuries, 2 amputations of the extremities, severe head injury. These 2 gentlemen, as well as their orthopedic residents, came there into the trauma bay, working with my residents, myself. We're transfusing blood. The neurosurgeon and his entourage came in, dealing with the terrible head injury, working with the ER doctors, resuscitating, and then taking the patient immediately to the operating room after the trauma bay. So these are terrible injuries that are life-threatening and quite often very morbid and leaving them with disabilities. So that's what orthopedic trauma really is. Over half of all trauma patients that we see in our ICU or in our trauma center have orthopedic injuries. And that's just not unique to us. That's all the level 1 and level 2 trauma centers in the country. Orthopedics predominates.
And level 1, you said you've been a level 1 trauma center for 21 years, right? Is that right?
We became a level 2 trauma center in 1998.
Okay.
And then we immediately worked towards level 1 trauma status, and we received that in 2001.
Okay.
So the next nearest one is in Albuquerque.
Okay.
And the next nearest one in Texas is, I believe, in Lubbock. There's 18 in Texas, including us.
Okay. And like Gilbert said, anything happens in this general area, and I say general area, that's, goodness, probably a 100-mile span,
including
if not more
New
than
Mexico.
That.
Or New Mexico, yes, ma'am.
Okay, goodness gracious. Dr. Adler, let's talk a little bit about, and Dr. Tyrock touched on it, but what are the most common traumatic injuries? I'm assuming it's car crashes, and I learned 20 years ago from Dr. Tyrock, I can't call them car accidents, they're crashes. And so in general, what do you see on, and I can't say a daily basis, but most often?
We see, because we're level 1 and we get everything for the surrounding, sometimes 200 miles, we see a little bit of everything. Car crashes, motorcycle accidents or crashes, people falling off buildings. People
falling off buildings?
Yes.
Oh, that just sounds like that's coming out of a movie or something.
Especially when people are changing their heating and air conditioning over on the roof.
Goodness,
Yeah.
okay.
And Christmas time.
And
Christmas putting up lights.
Time, the lights up.
Yes.
Yeah. People that got hit by cars, people that were explosions, everything you can imagine we see at UMC, in addition to all the stuff that the surrounding hospitals don't feel comfortable taking care of.
And on that note, Dr. Gonzalez, you're the transplant guy, let's talk a little bit about, and it's going to get gruesome, but that's what you do. And the audience kind of knows that sometimes we just get specific about this kind of stuff. But let's just say that there is a crash or an accident that happens and somebody loses a finger or two, and they're able to find the finger, and you see this in movies. What is about the time span that somebody may have? What should they do, number one? Put it on ice. Again, I'm just thinking about movies, but what should they do, number one, and what is the time span that is allowable for that finger or part of the hand or maybe part of the foot to be salvaged?
Well, the most common cause of amputations definitely are either table saws that we see in our communities or any type of sharp injury.
Okay.
We see a lot of injuries with grinders. Believe it or not, in accidents are the least of those amputations that we see. But in general, if you lose a part of your body, if we're talking about fingers or your hand or your forearm, definitely it's try to save that extremity, put it on a bag, put it inside, wrap it with gauze, put it on ice, and that's the way to transport.
Okay.
And the more distal that it is, the longer that it can wait to be replanted. The more
distal. Oh, I see. Okay.
So if you're saying, in other words, your fingers can, it takes a longer time for you to replant it. And then the more proximal that it is, it's more time sensitive. That's because all the muscle bellies and the more blood that has that part of the extremity. In general, we can say that 6 hours if you are talking about worm ischemia, which means that it's an extremity was not preserved, or you can do 12 hours up to 24 on some fingers if it's a finger that it was preserved in the proper way. And we see this a lot because some of our patients, they come local, but a lot of patients, they come from far away. As they mentioned, like sometimes they come from regions from Midland, Odessa, or just some like remote places in New Mexico. And these patients, many times, the accident happens on their factories. They get transferred to the closest medical facility. These patients, they go to the nearest hospital. They request the transfer. So by the time that the patients get here, the accident happened like many hours ago.
Right.
So if those patients, they got their extremities right preserved, they got higher chances to be reimplanted. Also, the mechanism is very important. When you have sharp injuries, that increases your chances to have a successful replantation. When there is more like maceration, more like a avulsion type, that decreases your chances. And definitely, as these type of shows, we never lose the opportunity to tell our patients stop smoking, because definitely smoking decreases your chances to have a successful replantation or any other surgery, because it decreases your chances of healing.
And circulation, all that good stuff. So feel free to go into that, because this show really is all about prevention. I know we're talking specifically about trauma tonight, but feel free to throw those in throughout the evening completely. Dr. Tyrock, I'd like to kind of piggyback on what Dr. Gonzalez was talking about and working with other specialists also in your field. So we were talking about extremities like the fingers, but then once you start going into, say, the wrist or the hands, you've got nerve endings and you've got all kinds of other stuff going on in there. So what is it that you all do? I guess that's an odd question to ask. Maybe explain a case study of what happens if it becomes more complicated, involving nerve endings, involving reattachment of muscles and ligaments and all kinds of crazy stuff in there. Who do y'all work with? Dr. Gonzalez, okay, we're done with that question.
He connects all those. He'll connect the nerves, the vessels.
Yes.
He does the microvascular repairs.
Yes. Okay, so if you don't mind, Dr. Gonzalez, and we'll switch back to you for a second, because that's what fascinates me. It's how everything works again, because I always think about the $6 million man. Now it should be the $6 billion man. Back in the day, when you rebuild him. But how difficult is it, and how long does it take in a surgery for all these other, again, the nerve endings, and I guess I'm specifically talking about the nerves. I feel like that's the most complicated part of it. How long do those surgeries take? And I know it's different with everything. I get that, but in general.
Well, I mean, definitely we need to be familiar with all the structures that they are on each finger, hand, forearm, or any extremity. So we have bones that they need to be reconnected. We got tendons, which are the structures that make your fingers move. We got blood vessels, the arteries that take your blood from your heart to distal, and the veins that recollect all the blood. And definitely those are the most time-sensitive anatomy areas that they need to be connected when the accident happened, and there are the nerves. So the nerves are like the cables that carries the electricity. In other words, if you have the switch on the wall, that's your brain, and then you have the cable, those are your nerves, and then you have the bolts, those are your muscles. So in order for you, that light to be shining, you need that connected to the electricity. Those are your nerves. So when you reconnect your nerves, there has to be a certain time that nerve recovery, in other words, the impulse needs to come from your spinal cord / your brain all the way to the area that has been reattached. So when you have a successful replantation, most of the times the bone heals. I mean, you might have complications with infections or other situations, but and then if your replantation is successful because your blood flow was restored, that's a good thing. But definitely the last thing to recover are those nerve injuries. So in other words, it takes months up to years, and it takes a multidisciplinary team to take care of these patients that fortunately we have them here at UMC. We have a beautiful team of people that ranges from nurses, social workers, the surgeons, all these people that work in the OR, up to the point that the occupational therapists and physical therapists that help patients to go through their injuries. So definitely when you have a complex injury on any extremity, the nerve injuries are the one to take the long to recover, and it can be months to years based on the type of injury that happened.
Yeah, that makes sense, just to get the body getting back to that point. And speaking about trauma centers, again, you're at level 1. And I think, is this the only one that we have in this area? Did I hear you say that earlier? And how, I'm trying to think of the workload on you all. So you were talking about this team of specialists. How many are there at any given time? I mean, I'd imagine there's busy hours. I'm thinking evenings and weekends are busy hours. I don't know. I would love for you to maybe chime in on that and tell me.
Typically weekends, summertime. Historically, July is our busiest month for the last few years. I think
tell me why. What kind of injuries usually coming in the summer?
Drunk people driving.
Oh, no.
We do get a lot of falls. People doing silly things, getting to arguments, getting to fights. Our number one reason for injuries is actually falls. And if you look at the data, it's kids. That's number one for kids is falls. And for the older patients, we always think, trauma is a young person's thing, but it's really not. And it's becoming more and more of a geriatric population. So falls are about 40% of our admissions.
Okay.
And we get a lot of transfers, and they're due to elderly patients falling. And they could not just necessarily be falling from a building or a roof. They can just be falling down the steps, tripping over a curb. I had one lady that fell off of over her cat.
Oh,
actually,
yes, that's
she did not do very well with that because she was on a blood thinner. So we get a lot of falls.
And on that note, it's interesting. One of the very first question from the audience here, for older people, if they feel like they're about to fall, exactly what you're talking about, is there a more safe way than others to try to catch themselves? And I remember us talking about this years ago, that just mentally, if you know you're going to fall, especially if you're someone who knows you're somewhat unsteady on your feet, how would you describe that to someone, just people that are listening at home? Would you put your arm back? Would you try to fall on your elbow instead of your wrists? I mean, I don't know if you...
When they fall, they break their hip and then they break their wrist. But you guys probably have a better answer than I do for that.
Dr. Adler, you haven't talked for a while. It's your turn, buddy.
I would just avoid hitting your head.
Avoid hitting your head. Nicely said.
I can fix any of the bones, but the brain doesn't like to be rattled around that much. So I would avoid hitting your head, whatever that takes.
Okay, that makes sense. And I think automatically, I know people that have wrist injuries, that's because they're trying to catch themselves.
A lot of patients, the older patients that fall, the problem is, and that's what he's talking about, is they're on blood thinners like Coumadin, the stuff you see advertised on TV, the Eliquis and Plavix and aspirin, or a combination thereof because of their heart problems or they've had histories of atrial fibrillation and stroke. So that's great for that. But when they fall, it can be devastating.
Right.
And that's why we worry about it when they hit their heads.
So on that note, once they get to the ER and they are having excess bleeding, what do we do then? Is there something that you are able to give them intravenously to help clot the blood a little bit, or?
There's various agents we give that help to reverse these clotting agents, and then there's the old-fashioned stuff like giving them platelets and plasma. But we do have some fairly expensive agents now that reverse these, like reverses Coumadin, reverses the other drugs that you hear about nowadays on TV.
Okay. And how long, más o menos, does that take? I mean, for something to take effect, say if somebody's really having an issue with bleeding, Dr. Adler?
Fairly quickly, yeah.
One thing I will say about the hip fractures, we have a new program at UMC working with a hip protocol, because hip fractures are a major concern, especially in the elderly, and the getting the patients fixed and up and moving quickly is very important for hip fractures, and we have set up a whole protocol within the last year or so. Been very successful with very good outcomes in getting patients with hip fractures fixed and up and moving, and with physical therapy and out of the hospital in a timely manner, which has been shown to have the when you do that successfully, the better outcomes for the patients.
Might you be able to describe some of that protocol? And I know hip injuries too are so different between one and the other, but often you hear someone who's elderly, they break a hip, and then not often, but it's not unoften that might be the end of, the end comes soon.
Sure.
So if you could maybe describe some of this protocol that you're talking about, what is it that you all
So we set up a pathway essentially where if a patient comes in the emergency room and they are diagnosed with a hip fracture, we fast track their treatment, in the sense that at some other medical centers they may be evaluated by multiple teams, but the reality is you're not going to change their general medical health. If they have diabetes, you're not going to cure them. If they have chronic heart problems, you're not going to cure them in that day. But the literature shows if you're starting to wait longer than 24 hours to do the surgery, the outcomes aren't nearly as good. So we have a system set up to get the patients to the operating room in less than 24 hours, to get if we're able to get their hips fixed, and then get them mobilized right away. Sometimes even in the recovery room, we get them up and moving around, and that's we've seen decreases in complication rates across the board because of this.
And here's my next question that's piggybacking with you. When you say getting the hip fixed, and Dr. Gonzalez, I'm going to bring this to you now. What does that entail? Because you're talking about, I guess, the biggest bone right in the body at this point, the femur leading up to the hip. So there are different types of hip breaks and hip fractures. Maybe you can talk about some of the most common and how most of the most common ones are fixed.
I'm going to defer the question to Dr. Adler, because
okay.
that's
all right.
That's
you're
what
the hip guy. That's right.
That's what
I
he
do a lot of
does
hip.
every day.
He's extremely okay. Go for it.
There are a couple different types of hip fractures, and where in the area of the hip it's broken will determine whether we replace it or just replace the hip with a new one, similar to what would happen if you had arthritis and you got a total hip replacement. And some of them do better with intramedullary nails, where we actually put something inside the bone but keep the native bone there and not replace it, depending on where in the femur and the hip the fracture is. So there's various options, but we tailor it to the patient's injury and base it off what will give them the best outcome.
So this is interesting to me, because a lot of times we'll do shows and it's someone it's an elected surgery. They know months or weeks ahead of time what kind of hip they're going to be, because there's so many different materials out there that you can use now. So someone breaks their hip, breaks a portion of their hip, and you've got a couple of hours to decide. And I'm putting you on the spot again, Dr. Adler. I mean, there's not plastic, but there's plastic, there's metal, types of plastic. How do you decide how to fix this particular hip?
Experience. But I think all of us being in trauma love the fact that the patient comes in and you make a decision, right away, looking at the patient's anatomy, looking at their condition, what needs to be done. And I enjoy the fact that I'm not sitting there planning this out for 2 months figuring out what I'm going to do. The patient comes in, I look at the x-ray, I talk to the patient, I know exactly what their level of function is, I can see the x-ray, know what to fix it with, how to fix it, what I'm going to use, and go. And I think Dr. Gonzalez and Dr. Tyrock probably feel the same way. He sees an amputated finger, he's not thinking, oh, what company, this, that, he knows right away, let's go to the operating room, I need to fix this. And honestly, Dr. Tyrock is the king of this. We see him in the trauma bay, he's thinking 4 steps ahead. We got to get this patient to the operating room right away, or this is what we need to do, and it's all planned out. It's basically like a well-orchestrated machine of planned out, just a system where everyone knows their job, and we're kind of leading it, but everyone has their role, and we take care of the patient.
And somehow it's this
team thing.
Yeah.
It really is. That's what's neat about trauma. It's not just one person.
It's a dance.
Doctor.
I'd imagine
it's
every time.
everybody.
I mean, sometimes it's the tango, sometimes it's the waltz. It depends on who's partner and how it's all going down. That's fascinating to me. And again, the general audience, including myself, we know the medical shows, you know, and so we watch this show often because I'm told this a lot. It's like, hey, yeah, I remember they were talking about this, and then Grey's Anatomy and season so-and-so, they had a similar situation. So that's what we know, the general audience. But you guys are living it and breathing it every single day. And so the idea that you have to make these decisions so quickly and get it right is impressive to me. Question here, I have, we talked about the different types of trauma cases, but I was kind of thinking about the trends. So there are trauma trends because there are new research on the horizon everywhere. And when we were just talking about hips and the different materials and how you go into things, training, I'd imagine you guys do training all the time. Are there any new trends in the world of trauma that we can talk about that is interesting enough to you to bring up during the show? And Dr. Tyrock, I'll start with you, but feel free to kind of think about that as we're going through it.
So as a non-orthopedic surgeon, the things that we deal with as a trauma surgeon is we do things less invasively if we can. We have interventional radiologists who are putting stents in for blood vessels that are injured. In the past, we would make big incisions into the chest, high risk of having the patient be paraplegic, about a 25% incidence of paraplegia, but they survive, 12% incidence of renal failure, but they survive. Now they can put a stent in and they can be up and walking in a few days. We have ways of draining fluid collections that accumulate after a laparotomy or abdominal surgery. We have neurointerventional physicians.
And describe, if you don't mind, because this is fascinating as you talk. So if you're talking about collecting of fluid, because that's a major problem.
It's usually an abscess.
Okay.
Pus.
Okay.
Or draining.
And so is it a tube that would go in? Is it just tubing in different areas? How would the drainage then?
Either they would put a needle in and drain it and aspirate it.
Okay.
More likely they would put a drain in and we'd leave the drain in for several days until the collection resolves.
Okay.
We're putting a lot of stents in that we used to operate. And now we're stenting. The neurointerventional people that do like a stroke team. We have a stroke team at UMC. But they're also putting stents in patients that have carotid injuries and vertebral artery injuries, much less morbid than it used to be when we were operating, and better outcomes for the patients.
And would you say this has been happening for the last decade, less than that?
Some over a decade, some less.
Okay.
We're even having devices to stop arterial bleeding, like in the pelvis, that you can put a catheter up and we can inflate a balloon and reduce the bleeding to the pelvis. Or once again, the interventional radiologist can embolize, meaning clot off those blood vessels. So that's all things that we're doing in a more minimalistic approach. We're doing things with tourniquets. 20 years ago, if somebody would have put a tourniquet on a patient, we'd scream at them and say it's malpractice. Now we're teaching high school students how to put tourniquets on because unfortunately all the stuff we're seeing, in schools and like we saw in Las Vegas. And so that's something we're promoting at UMC and other trauma centers in town, including the Border RAC. We're I think we've now taught at least 3,000 people in the region how to put tourniquets on. So.
I'm going to deviate a little bit because I haven't talked about the Border RAC in a while. I would love for you to brag a little bit about what Border RAC is.
Okay.
Just a smidge, because I think the people out there don't know, and it's such a fantastic program. It really is.
It used to be called the Far West Texas and Southern New Mexico Regional Advisory of Trauma.
Yes, I remember reading that whole.
Nobody liked that name, so it was abbreviated to Border RAC. So going back historically, the state of Texas set up the state into 22 trauma service areas. And each trauma service area had a regional advisory council. That was the old Far West Texas name. And then we changed our name. But it's not just trauma. It started with trauma, but now it's grown to providing trauma care, cardiac care, stroke care, injury prevention, other types of prevention, meaning, take care of diabetes, take care of your blood pressure, things like that. It's now going to neonatal intensive care. So the neat thing about that is it's not just one hospital doing it. It's all the hospitals in the region doing it, including New Mexico. And it's not just the hospitals. It's the pre-hospital personnel, the paramedics, EMS, ambulance companies, as well as the flight crews. And as you probably know her, Wanda Helgeson is the executive director of our Border RAC.
Say hi to Wanda for me, would you?
Yeah, I'll see her next Monday.
She's fantastic. Okay.
So it's a team. It's a group of people that are coming together of various disciplines, but we're all doing the right thing to enhance medical care and health care in this region.
That's a show I'd like to do again. We haven't done that in a while, but that is fascinating to me, and what's happening in our backyard. And Dr. Gonzalez said that too. It's
we have
El
a big
Paso,
backyard.
fine, but we have a
Yes.
huge backyard,
Yeah.
and then the side yard and everywhere else too. I've got some questions here from the audience. I've got several more that we have that are prepped, but we were talking about, and Dr. Adler, I'm just going to throw this your way. Have you been at UMC this entire time?
I've been at UMC for about 2 years.
Okay, so here's a question from the audience. What does UMC have that other facilities do not? And that's something too, because I think that there is sometimes a confusion between the Texas Tech Paul Foster School of Medicine, with UMC, with the different hospitals. So this might be a nice time, and whoever wants to take that. I know Dr. Tyrock, you're welcome to take that as well. But in general, what is different about UMC in this trauma? Because I think that's something that people really need to understand about the true level 1 trauma unit that you all have.
I think when we talk about orthopedic trauma specifically,
Okay.
UMC is the only place that has a dedicated full-time orthopedic trauma surgery surgeon available 24 hours a day, 365 days a year. If you're at a level 2 or level 3 center, you may have an orthopedic surgeon, but you probably don't have a trauma surgeon, since there's 4 of them full-time in El Paso, and all of them are at UMC.
No kidding. I didn't realize that. Okay.
So if you have a severe orthopedic trauma injury, UMC is the place to be.
Okay. I like the way you said that. Question from the audience. It doesn't really necessarily have to do with trauma, so I'm going to skip this for just a second, because I do want to talk about some of the training that you all do, because I think that's also very important, in talking about Border RAC a little bit too. But for departments, and we were talking about you all leaving for training, but it's very important too for people to know what level 1 means, what level 2 means, what level 3 means, and the training that goes along with that. And Dr. Tyrock, I'm going to give that to you if you don't mind, because I know you've been involved with this from the beginning. But when you were a level 2 back in 1997, you said, and then became a level 1 in 2001, what all goes into that for the audience to know?
So to be a level 1, you really have to emphasize your scholarly activity, your academic part, including research. So all of our departments are doing research in various types of things. We had an excellent presentation this morning. We have a monthly trauma grand rounds, which is multidisciplinary, meaning all the departments are attending: neurosurgery, emergency medicine, orthopedics, anesthesia, and et cetera, including nurses and medical students and residents. So we have about 100 people attend. We had a talk about how to deal with civilian gunshot wounds, including fractures. Dr. Wynn is another orthopedic trauma surgeon that we have on staff. She's excellent. So is our husband, Dr. Rich. So they came about 2 or 3 years ago too, I think. Yeah. And she brought some of her work that she did from where she came, and then she's carried on this research here, and she presented her work to the audience. So we have an annual Rio Grande Trauma Conference. We're now, December will be our 19th year. So we bring in outside speakers, including local experts from our trauma program, as well as the community doctors. One of the trauma surgeons who's excellent from the Level 2 Trauma Center at Del Sol, he's going to be speaking also. So we are bringing new cutting-edge technology and information that we've learned, so we can learn, because we're always continuously learning. Right. As well as trying to teach the new residents and medical students, as well as nursing staff.
And I'm going to talk a little bit about, and I'm going to ask both of you because you're young. But first, the station wanted me to let everyone know that we are streaming live on Facebook and on YouTube. And the way I'm transitioning that is to medical students, because you guys aren't old, but we're old. That's right, you're old. I'm not old.
That's right.
But the training and advice that you may give to these youngins, and then what you all as old guys to those medical students, people who want to work in trauma, medical students and or even kids going to college that have a biology degree that really are thinking about what kind of medicine they would go to. Because what we try to do with this show too is try to involve the students as much as possible, and that's a segment that we're going to start using a little more often. What would your advice be? And I'm going to start with Dr. Tyrock, but I want Dr. Adler and Dr. Gonzalez to also think about what you would say to a medical student on why you guys do trauma, why you love it, because you love it. I mean, I could tell when you were like, yeah, I like that, I have to plan this out, and I have to make these split decisions, and it's a rush, I'd imagine. And within a rush and adrenaline, that's where we do our best work. But in general, what advice would you give
Well, first of all, trauma's fun.
Trauma, see,
Yeah,
and,
it's not
who
a job.
thinks that, right?
Yeah, I mean, when I take call, because we spend the night in the hospital, it's like an adventure. You have no idea what you're going to walk into that night.
Right.
And you have to be ready for anything. You know, you may have a gunshot to the neck you got to operate on. You may have a gunshot to the rectum you have to operate on. You may be operating on, I don't know, anything. You're putting a chest tube in to drain blood from the chest. So you have no idea what's coming in. So that's exciting. You have to sort of remember what you learned as a resident, because you may not see it for years, but you got to deal with it.
Right.
The other thing I like about trauma, you don't get to pick your patients.
Ah.
So you can't discriminate. You know, you may have the biggest jerk come in, you may have a schizophrenic come in, you may have a saint come in. And so you have no idea what's walking through the door, but we treat them all the same.
Right.
And that's what I like.
Right.
So everybody gets taken care of the same way.
Nice
Not
to
just by
say.
me, but him and everybody in the hospital. And that's not just at UMC. Every hospital, all the trauma centers do that. You don't pick your patients. It's what comes in. And that's neat. I like that.
Dr. Adler's nodding his head. So did you know you wanted to do trauma from the beginning, or is it something that you fell into, or you checked it out? It's like, hey, this is exciting.
I knew as a medical student that I wanted to do trauma.
Okay.
There were a lot of people that tried to convince me to do other things, and I knew that trauma was what I liked doing.
I think of it as stressful, but some people, it's what people thrive on.
Yeah, it's not stressful when it's fun and when you have a passion for it. There's always going to be stress. Things don't go right. There's going to be stress, but overall, when you have a passion for it, I think it's a lot of fun, and just like you said, and just.
And when you say you knew you were going to do trauma, what was it about trauma that you knew you had to? This is something you're getting into. Like when you said as a medical student. Is this as you were going into medical school, second, third year? Because we've got a first year over here, we've got a second year over here.
Yeah.
Pretty much immediately you knew.
I knew I went to the University of New Mexico for medical school, and I remember being very eager when I was on the IC rotation and the trauma rotation to go up to the roof and help them take the patient off the helicopter.
Wow.
And knew that this is what I wanted to do, and. Yeah, I knew.
And I'd imagine just that surge of knowing that you're helping someone out.
Yeah.
You know, that sounds like it's the warm fuzzy part, but I imagine it matters. Dr. Gonzalez, how about you?
I'm going to rephrase Adam a little bit. Medicine is about passion. So definitely, if you're going to choose this pathway, make sure that you want to do it because that's what you want, because that's what you enjoy. Don't think of medicine because it's going to give you a status or it's going to give you money or anything like that. No, this is about passion because you really got to enjoy what you do every day. If you want to do the right thing, not to mention that we're dealing with human bodies. So for those kiddos that are out there, if you're in high school and you're thinking of going to med school, you got to prepare yourself to go into med school. Once you are at med school, you got lots of opportunities to interact with the different departments to choose what you want. Finally, when you choose your specialty, like if you choose orthopedics, then you have 5 years to go through the different pathways in order to end up what you really want to do. Because like for Adam, that he does specific trauma, me, myself, that I do hand and micro, it's a very specific part of medicine that it is. So once you are in residency, because you were asking what does it take you in order to become what you are right now, then you gotta do another training, which is a fellowship. That's after residence. Some people we do different fellowships based on what you really want to get into, but definitely this is our passion. So make sure that you know what you want, you enjoy what you're doing, and you are capable of doing it. Because you might say, oh, I will be the best person treating hearts, but you don't have the skills.
Right.
So that's what training takes you into. So you learn, you discover your skills, and you really feel the passion where you're heading to.
Right.
The passion is correct, but let's not just talk about the doctors.
Yeah.
Because it's so rewarding when we do a trauma resuscitation, or even we get from the trauma room to the OR and then to the critical care unit to see the passion of the nurses and the techs and the respiratory techs, even blood bank who's running up there with multiple coolers of blood. They're doing it because they want to, not because it's a job. And that's what's really neat. And I'm leaving out some people because the physiatrist, the physical therapist, the speech therapist, they go there, you watch them, they're doing it, and because they feel good doing it. So they have passion. So you don't have to go to medical school to say, I want to be really good at something.
Right.
You could do it in nursing school and respiratory radiology techs. I mean, when I'm watching our CAT scans or the arteriograms, these techs are just professional.
Right.
And you know they're doing because they want to do it, not because they're doing a 12-hour shift to make money, because there's easier ways of making money. But you see they love it. And that's what's really, and that's so rewarding. You see a badly injured trauma patient, and then 2 weeks later they leave the hospital, and then a month later they come back, and they want to meet the nurse, they want to meet the techs and everybody like that, not just the surgeon.
Right.
So it's really
exactly.
neat.
Yeah.
You know, it's just
all the people that they've interfaced with.
The ER docs, the anesthesia, everyone. It's really neat.
Yeah,
so,
I can imagine it is.
It's a team.
And as Dr. Adler was saying too, with the hip, but I think with everything, it's experience. And the experience is different every single day, like you were talking about. And
it's never boring.
It's never, I can't imagine it being boring. No. So here's a tough question. Talking about experience and finding something different every day, I would love for each of you to think about that one case that came in. It's like, oh my gosh, I'm totally not prepared for this, and what you learn from it, because that's one of those things too. You think, okay, because again, I'm going to medical shows where I see on what medical show A, B, and C that there's a tree trunk through a guy's abdomen and he's alive, and he's like, okay, how do we take care of this? I mean, it's funny as we're talking about it, but those are things that actually happen. Give us some weird, off the wall examples of what you've seen that's like, wow, I would never have expected that.
Some I can't describe. It wouldn't be appropriate. One of the most rewarding, and I have a lot of rewarding ones.
I'd imagine you do. Yeah.
We all do. We all do. And, you know, we see so many patients, but some stick out. One is a girl that was injured in Mexico. Innocent girl, was in a grocery store, cashier. She had her initial surgeries in Mexico. She came to me sick as a dog. I think we did 16 operations on her. She spent 350 days in our hospital.
Oh, my goodness.
While she was in the hospital, she got married. And then after she got out of our hospital, she went to UTEP eventually and became a U.S. citizen. This girl was innocent. She wasn't anything with the cartel.
Right.
And that was so neat because there were so many times I thought she was going to die.
Oh, my gosh.
And there was times I was like, why am I still doing this to this poor girl? It's just inhumane almost, but she survived.
Right.
And it was
and
really
talk
neat.
about that team. I mean, the team that's been taking care of her for a year
she still comes back to the hospital to visit the nurses and everybody.
Right.
So that's rewarding.
I bet.
So we all have stories like that, though.
Okay, Dr. Adler, I need a story from you.
There was a patient, actually, it was interesting enough that the UMC Foundation did a video on it that's available online. There was a patient that I had that was, didn't make the smartest decision, was riding a dirt bike out in the middle of nowhere. No one really knew where he was. And he went over a cliff that he didn't know was there.
Oh, dear Lord.
Fell down about 200 feet.
200 feet?
Yeah, dislocated his hip. And but there was no cell phone service, so he had a dislocated hip, and he dragged himself to cell phone service, and then was able to contact someone, and then the patient was brought into UMC, and by the time he dragged himself for a mile and a half, his hip was non-existent. He'd worn it out because it wasn't in the proper position, and it was wearing against bone that shouldn't be rubbing against.
This is another movie.
Yeah, so we treated his hip dislocation, which also had a pelvic fracture, with a total hip replacement. And when I saw him 6 weeks after surgery, he walked out of my office without a sign of any injury.
Oh, you're kidding me.
He was walking, no limp, nothing. He was just went about his life. And I think it was a very good example of how we can take someone in the worst day they can imagine.
Right.
And sometimes we can make them whole again.
I'm assuming he didn't have an open wound. I mean, or did he?
No, he did not have an open wound.
Goodness.
Yeah.
Okay. And so 6 weeks later, you said?
6 weeks later, he was walking. He walked out of the hospital without a limp. His 6-week follow-up in my clinic, when he came back to see me after we'd done all the surgeries, 6 weeks, he'd finished therapy. He was walking by himself. No limp, no cane, no walker, anything.
So you say dislocated hip. Was anything broken in there?
Yeah.
Did you have to replace any parts?
So we actually had to replace his whole hip because it was all broken.
Oh, my gosh.
Yeah.
Okay. Well, that's one of those things, too, the healing process. And that was going to be one of the other questions, but I always feel like that's the tried and true, tired questions, like how long does it take to heal? And again, there's never a one answer to that. Dr. Gonzalez, I'd imagine you have all kinds of stories with the things that you do. As he smiles and nods. First of all, before we go any farther, I would like for you to pick up your feet really quick. And I need people to see your boots. He's got the coolest boots on. He's trying to cover. Oh, there you can see them right there. He's trying to cover them up earlier. He's thinking, oh, my pants are not long enough. But You know what? That's a character thing. So I'd imagine that as you're walking around the hospital and doing different things, people have different reasons that they love each and every one of you.
Those boots are about as loud as his suits usually are.
So they can hear you
Or
come
his
down the hall.
motorcycle.
And his motorcycle.
Dude, you're a trauma.
Yeah, I know.
We've had multiple conversations about this.
Don't touch it. Stop it.
All right.
It's a different story.
So many conversations
I don't think
about
I'm old enough to be your mom, but just be careful on those things. Okay, give us your story.
Well, as I say, there are
Or
many
two or
patients.
three.
I mean, I can remember one patient. His job was taking care of people, so he was attacked with a machete. He was injured so many times on all his extremities. He came as a level 1 to our hospital. We ended up doing like 52 procedures that day. That day, yeah, we spent like 6 hours on him or something. The guy has the best attitude in the world. He has had other procedures. This happened maybe, I don't know, 6 to 8 months ago.
Wow.
And right now, he pretty much recovered everything. He recovered fantastic. And now he's a huge advocate and volunteer for the Crime Victims Program. So it's amazing how some people that they get attacked or injured in certain specific ways, now they want to give back to society once they recover.
And those are beautiful stories, and I find that to be more in the human condition than the opposite. And I know people think I'm naive, and so be it. But I really think that is more what we see. What makes me curious when you said 52 procedures within 1 day. Just name a couple of those procedures of what you're talking about.
Well,
this is one patient.
Yeah, just name if you're being attacked by a machete and you're trying to protect yourself. You get your hands, your forearms, your elbows, your legs, like cut in several different places. So you get bone injuries, tendon, muscle, nerves, vessels. So you need to try to repair like all of them in order to get this guy back in function.
Goodness. And so he's, like you said, he's an advocate now.
Absolutely, yeah.
Okay.
He's got a great heart.
Excellent. And that's again one of what you guys must see. I've got questions here from the audience about simple emergency room and 911. So I do want to pretend, like, kind of put our border rack hat on for a second, because I've got a couple of questions here too about when is it bad enough to call 911? When is it okay to drive yourself? And this is again where you were talking about earlier, just throwing out some education. Stop smoking. When you call 911, don't take yourself to the hospital. I'm throwing this out to all three of you. So if someone falls, they realize that they can't move, it might be a hip injury, do you call 911 or do you wait it out? Okay.
No, call.
So just go on that note and feel free to use this as an educational moment to the people at home.
Okay, first of all, the non-traumas, if you're acting like you're having chest pain, call 911. Don't drive yourself. If you're starting to have slurring of speech, drooling, weakness of one side, call 911. You're having a stroke. If you're in a car wreck and you're injured, don't try to drive yourself to the hospital. You need to be calling 911, get an ambulance to pick you up.
And explain, if you could, why are we doing that? So once the ambulance gets there, the ambulance is like not a mini hospital, but it's like a mini clinic for the most part. And if you can describe what many, if not most, ambulances have equipped with, and the fact that they can call ahead and all that.
Well, they're paramedics, and they're very well trained. They know how to take care of you. They know how to resuscitate. They know how to resuscitate in the field better than a doctor does. I've been in car wrecks, and I try to help the patient. I realize there's not much I can do. I don't have the equipment. I don't have the splints. I don't have the oxygen. I don't have the airway equipment that they do. So I just stay out of their way and let them do the job. So that they know what to do. They're the experts in the field, and they know how to get you to the hospital expeditiously.
Nice. We're at that time in the program. We have less than 10 minutes to go. And I didn't tell you this ahead of time. Dr. Tyrod kind of knows the routine. But what I like to do is stop all questions and look at all three of you and think of what you may have wanted to speak about tonight that maybe we haven't talked about yet, or if there's something we talked a little bit about that you'd like to expand on a little bit. And Dr. Gonzalez, I'm going to start with you, just because you're on the other end of the couch. But is there anything that you would like to tell the audience this evening when you were stuck in that huge traffic accident coming over here? By the way, I do have to say that could have been a trauma issue today. I don't know if you all were...
There was no injuries.
And for those of you, I know that the show is live right now, but it gets aired back later, but there was a huge accident right on the Stanton Bridge I was downtown and people could feel the accident, but nobody, as far as I know, was hurt. knock on wood. So we could have been having a very different discussion tonight, and you guys might
Or nobody
even have
would
to
have
be
been
at
here.
work. Exactly. But in general, is there anything that you'd like to talk about this evening that we haven't touched base on yet, Dr. Gonzalez?
Well, two very quick things. Number one, you were talking about what the novel things that we're doing right now. So about nerve injuries, that we have these structures that they get damaged and then they are very difficult to recover. Now we're doing nerve transfers, which pretty much in the world we've been doing this for the last 5-10 years, and more we are discovering better things about it. And nerve transfer pretty much means like taking a nerve, an expandable nerve that is working, into another nerve that is not working in order to try to recover or restore the function. And then these more and more they are working very well. So this is an excellent option for patients with nerve injuries in order to recover function. And the other thing that I wanted to mention is, like you were saying, when to call 911, because sometimes people they call 911 for something that they shouldn't. But on the other hand, you also have patients that they feel that their injuries are not too severe, and they don't seek medical attention for days until it gets worse. So we, at the UMC, we not only treat trauma, we treat emergency in general. So there are many times that we have emergency like infections. We have lots of infections. And many of these infections is because it's a condition or an injury that happened days ago. People didn't treat it properly. They wait for days, and they ended up coming. Here in El Paso, unfortunately, we have an epidemic. Lots of patients, lots of people, they are diabetic. So being a diabetic is a condition that precludes you to have an increased chance of infection. So if you are diabetic, or you are not diabetic, but you have any puncture, any cut, any whatever, don't think that you're going to take care of yourself in the proper way. So it's better to seek medical attention beforehand when it's already complicated.
Right. And that's an excellent point, because we haven't talked yet about infections, because usually if there's an open wound, that is one of the major issues, I would say. And you talk too, it's all about time. If you can get to the hospital on time, if you can get to the paramedics, if you can get into the ambulance and they can start administering. So I appreciate you saying that. That makes all the difference too. Dr. Adler, anything that we would like to expand on your end, or that we haven't touched base on yet?
One thing about orthopedic trauma that we haven't really discussed is basically fixing bones that didn't heal properly. So
right.
not all of my life is filled with just taking care of the patients that come in by ambulance and helicopter and have their bones in places they're not supposed to be. Sometimes either they were treated and the bone didn't heal properly, or it healed in an angle that doesn't help their function. And part of my job is to go back and fix things that didn't heal properly. And one particular case that I think emphasizes and shows what we do at UMC is we had a patient that had been operated on. Dr. Gonzalez and I had been operated on by other physicians about 8 times, trying to get their humerus, their upper arm, to heal, and nothing was working. And the patient was in severe pain, and I saw him in my clinic, in my office multiple times, and he just had unrelenting pain, and it was getting very severe, and it was interfering with his family life. So Dr. Gonzalez and I took him to the operating room, and Dr. Gonzalez, being the extraordinarily talented microvascular surgeon he is, took a live piece of bone from the patient's leg with the blood vessel still attached to it, and then connected to a blood vessel in the arm, and then I went in and put the bones back together and covered it up, and to get the bone to heal.
And so from there, you were able to get the blood flow from, as you were just talking about, from a different part of the body to, I guess it just starts molding itself together and starts healing that way?
So it healed with the live bone. Part of the problem was that after so many surgeries, when you ever do surgery, you disrupt the blood flow because you're cutting through little tiny vessels and everything like that. And so blood is the most important thing in getting anything to heal. And so we took a healthy piece of bone that we could reattach to the vessel in the arm and put it in there so it would heal. The arm, and after the patient had been through 8 and 9 surgeries, and here we are getting the patient to heal by taking bone from elsewhere that's still connected to blood vessels.
Does he send you guys Christmas cards now every year?
He's
gonna.
Yeah.
That's impressive, and that's one of those things too. We were talking earlier about training, and sometimes that's on-the-job training. I mean, it's just one of those things that you're trying to figure out how to make this person better, and he gave you the go-ahead, and it worked. Way to go, guys. That's impressive. That's really impressive. Dr. Tyrock, I think we're down to like 3.5 minutes. Is there anything else that you want to talk about real quick before we get off the air?
Yeah. Unless we'll go to commercial.
No, I wish. No. No, actually, I'm very happy we don't have commercials. This is a straight-on program.
I guess just to, since I've been here 2 decades, just to reflect a little bit about Thomason Hospital.
Right.
Something that I still like to call it Thomason.
Yeah.
Just to see how we evolved as a hospital to a University Medical Center. How Texas Tech, which was a regional campus, evolved to, Paul Foster and then Texas Tech Health Sciences Center. How, in 1998 we had 1,200 patients. When we became a level 2, we were so excited and proud of that. And then to see how we went to become a level 1. And now almost 20 years later, we're still a level 1, and how, we're up to 3,000 trauma admissions a year. About 40% of our patients come to us in transfer from other hospitals, not just in El Paso, but in southern New Mexico. We have a catchment area of 1.2 million. We have all these specialists, these gentlemen. We have the oral maxillofacial group. We have the plastic surgeons. We have the cardiothoracic guys, the ophthalmologists, the urologists. I can go on and on and on. And just to see what we were to what we are now, and knowing that, we were so proud when we were just presenting case reports at meetings, and now we're doing prospective clinical trials and all types of studies. And we're going off and giving talks at national and international venues. It's just neat to see where we were and where we are now, and knowing that, we're strong, UMC's strong, and we're a strong trauma system, not just UMC, but just the city and the region, and just how healthcare has improved in El Paso.
Yes.
And not just for trauma, even for cardiac and
Right.
stroke, but mother-baby care, all those things. And it's just neat to see where we were and where we're going. And I'm not that old. I'm only 57.
No, I'm with
so I hope
you.
to be here a lot longer to
Again,
see where we are in 10 years and 20 years from now.
My daughter's
And,
21, and we started the show. I started the show when she was 3 months old. She was in the back, and somebody was watching her. So I'm
Yeah.
with you, and that's how I
Things
clock
have
how long
changed.
we've been doing this. And it's absolutely amazing
We're just healthcare
to
in
me.
El Paso.
Yeah, we
Yeah.
can have the same cardiac show or the same prostate cancer show, and every year it's completely different because of the time that we've had doing this.
A few weeks ago, I looked at the top 20 the top 20 largest cities in the country, and I think El Paso's 18th. I'm going, we're better than those cities.
Nice.
We can be better in healthcare than that, and
Yeah.
we've come a long way. We got a ways to go, but we're moving.
But
that
we're
way.
doing good.
Yes,
We're
ma'am.
doing good. We've got about 30 seconds here, so I wanted to let people know that if you wanted to watch the show again, you are welcome to do that in several different avenues. You can do that at kcostv.org. You would go to watch, go to programs, find local programs, and you'll find the El Paso Physician. And you can also do that on the El Paso County Medical Society site, and that's epcms.com. You can also look on Facebook and find KCOS, and you will find this. It's been streaming live, but you will find it restreaming and on YouTube as well. So there's all kinds of stuff happening here at KCOS. We appreciate you being here. This has been really the dynamics of orthopedic trauma. It's not just wear and tear. I'm Catherine Bird. You've been watching the El Paso Physician. Good night.